We have a lot of people on the program today. We are almost close to 100 participants, and that is amazing. All right, so we are very much ready to start today's presentation. It's going to be one of our free virtual classes that we are doing for our Nclex test takers. And today we have a pleasure of having our very own boss, our best boss, one of the bosses that made very tremendous impact in Decency Nclex Academy. Today, she decided to remember us. Okay, and she's here today. She came prepared. And then we're going to be taking questions at the end of her presentation. I'm just going to give like 2 minutes for people to come in. And within these 2 minutes, I just want to get to know everyone, where you guys are joining us from. Please, on the comment section, please just tell us where you're joining us from. We know people are joining us from different parts of Africa. You know, we have people from Ghana, from Kenya, from other parts of the world, like the US, Jamaica, everyone is here. So if you're joining us, go to the comment section and let us know where you're joining us from. We'll be glad to know where you're joining us from, just to get to know you, get to know your location. While we are doing that, if you have any friend that is supposed to be in this meeting today and that person is not here now, please do me a favor and just let the person know that the program has started. The person might have 1 or 2 questions that he or she will throw in that will make even you that is inviting the friend understand the topic better. So please and please kindly let your friends know that we are live on the program. Okay, thank you so much. So let me go to the comment section and know where people are joining us today from. The last time we had this, we had people from all parts of the world, and then today I see someone, I see Canada, Elizabeth from Canada, I see Chizoba from Nigeria, Uzamaka from Nigeria. Please, 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 let us know where you're joining us from. Princess from Nigeria, Neka from Nigeria, Obinna from Nigeria. We have a lot of Nigerians today. You are all welcome to the program. Like I said, we're just giving a 1 minute grace for people to join in. Use this time and tell us where you're joining us from. We have Ope from Saudi Arabia, God's Gift from Nigeria, Adobe from Nigeria, and who else do we have? Glory from Nigeria, Benjamin from Ghana, Agnes from Nigeria, and Grace Charity. Someone, her name is Sekina, is from Saudi Arabia. We have Joke and Nolare from Nigeria, Faith from UK, Lydia from Nigeria. All of you are all welcome. You are all welcome. Let's take a quick minute break to go to let our friends in, and then we'll come back to looking at people who have joined us and where they are joining us from. All right, so right now we are close to 150 people on the program. Yes, and they are joining in now, and we are going to let our host, we're going to make our host our speaker today, host, and then we'll let her begin her presentation, because right now we have a lot of people on the program already. So please, please, please kindly follow through, listen to all that we are going to be discussing today. At the end of the program, you will have the opportunity to ask your question, okay? Now, it is my very own pleasure to welcome to the spotlight, one of our very best boss. So one of the thing that you should expect from her is she's going to simplify this area that a lot of people has been like, oh no, is he psychiatry? I don't like psychiatry. This is some of the opportunity you're going to get today, is to discuss and talk one-on-one with someone who not only likes psychiatry, but has taught psychiatry in Decency Academy for over 2 years. And she has been good at it. She's working currently. She's able to bring in life experiences, even from the clinical area. So join me as I make welcome our very own boss, Abisola Oluwole. Abisola, the stage is yours. Thank you for honoring our invitation. We are so excited that you're here today. How are you doing? You can unmute yourself, ma'am. Yeah, we can hear you. You can unmute yourself, or let me see if I can unmute you. You're muted.
Can everybody hear me now?
Yes, I can hear you. Every other person in the program is muted. So the way we set it up is everybody is muted upon entry. So we can have some decorum to be able to teach, and then they listen. At the end of the program, we can ask our questions.
Okay. All right. Good evening, everyone. Thank you, my boss, for really making me look like a gold.
You are our gold. Come on. You went through this journey with us. You are now in the United States. You're living the dream. And here are people in different parts of the world looking up to become, like you in the nearest future. So here you are. Just show them the way and just tell them how to ace this Nclex, and they will be with us shortly.
Thank you for the honors. Thank you so much. Good evening, everyone. My name is Abisola Oluwole. I'm currently in the United States, and I'm currently in Louisiana. Well, it's been good so far, but I know it's not an easy journey starting, but the best thing you have done is to prepare yourself, and that's what you're doing now. And I really appreciate everybody for being here to actually want to learn one or two things. Today we'll be talking about psychiatry meds, and like Boss said, I really like psychiatry and I like pharmacology generally. So I'll make sure I simplify it to the best of my knowledge. And if you have any questions, like the boss said, just write it down, and at the end of the class, I'll take any questions and we'll discuss them, and then we'll get to learn more from here. I'd like to start now. Boss, can I go ahead and dive into the presentation? Okay, I see you. Okay. Okay, all right, we're good. Okay, today we'll be talking about psychiatric medications. I'll basically just break down what I need to talk to you about today. I'll just focus on introductions, I'll just kind of brief you on psychiatric medications. We'll talk about the group of psychiatric medications we have. Basically, I'll tell you what they do, the examples, and the need to know, okay? What is really important that you remember for your Nclex exam. And we'll have questions, okay? All right, when we are talking about psychiatric medications, I want to believe everybody knows that psychiatric medications are medications that are used in treating mental illnesses. But what we might not know before, but we're gonna know today, is that psychiatric medications actually work on the different neurotransmitters in our brain. And this is what makes us reason, what controls our emotions, what makes us good in our decision makings, and other things that makes us humans, okay? So psychiatric medications, like I said, are psychoactive drugs that are taken to exert effects on the chemical makeup of our brain. And like I said, the neurotransmitters are the chemical messengers that our body cannot function without, okay? Their job is to carry informations and chemical signals from one neuron to the other. And the common neurotransmitters that are very, very important in psychiatry is the dopamine, the serotonin, the noradrenaline, acetylcholine. And as we go through each class of psychiatric medications, you will see how this thing actually works. I'll kind of because I kind of put it in my presentation on each drug, on which neurotransmitter they actually affect. Okay, so the group of psychiatric medications we have are the antidepressants, the mood stabilizers, the antipsychotics. Okay, we have the anti-anxiety or the anxiolytics. We'll talk about the stimulants and we'll talk about the sedatives. Okay, if I'm going too fast, just type in the comment section, boss, you're too fast, because I'm known to actually talk a little bit fast. So if I'm very fast, let me know. Hold on a second. Hold on. Can everyone see my screen now? I want to believe so. Okay. Like I said, with the group of psychiatric medications we have are the one listed below, and that's what we're going to discuss today. So I'll start with my antidepressants. Okay. These are drugs that are actually used in treating depression. And antidepressants, they hinder the breakdown of serotonin, norepinephrine, and dopamine. And like I said earlier, these are the neurotransmitters in our brain. And we have some subgroups of antidepressants. We have the selective serotonin reuptake inhibitors, commonly called the SSRIs. We have the monoamine oxidase inhibitors. We have the tricyclic antidepressants. We have the serotonin norepinephrine reuptake inhibitors, and we have the atypical antidepressants. And we're going to talk about them one after the other, and we're going to talk about the contraindications and things you really need to put in your mind whenever you're reading about these medications. We have the selective serotonin reuptake inhibitors, okay? They inhibit serotonin uptake and elicit an antidepressant responses. And the example of these medications are citalopram, escitalopram. I know the names are a little bit, very difficult, but then I kind of make it rhyme. That's why I put the pram and pram together, the tin and tin together. And we know that sertraline is the one that is a little bit off. So how I would advise you to actually learn these drugs is the more you say it, it will become part of you. And when you see it, even if you cannot pronounce it well, you will know what it is. So we have the citalopram, the escitalopram, the fluoxetine, the paroxetine, the sertraline. Hold on. Can everyone hear me? Okay.
Sorry to interrupt. I think there's a view that is obstructing us from seeing your screen very well. So I want to see if we can fix it, before you continue, just so everyone can follow. Okay.
Okay.
Yeah. So it's just the logo.
Okay. Let me try.
Yeah. Give me 1 second. Let me see how we can do that from here.
Okay.
Okay, so spotlight everyone and spotlight you. Okay, and then let's do this. All right, so I'm kind of making you host now. Yes.
Okay.
Sorry to interrupt. It's just that I want everybody to follow, and some people were already saying the view is obstructing them. So.
Okay. All right.
All right. Yeah. Okay, try to share your screen again and let's.
Is it good now?
Yes, it's awesome.
Okay.
Go ahead.
Okay. Let me just go back one bit so in case anybody missed anything. I said we are talking about the group of psychiatric medications we have, and we have the antidepressants. Okay, these are the drugs that are actually used in treating depression, and they hinder the breakdown of serotonin, norepinephrine, and dopamine. And we have the subgroups of antidepressants, and the first one we are talking about today is the selective serotonin reuptake inhibitors, and that's what we majorly call the SSRIs. And like I said, the selective serotonin reuptake inhibitors, they inhibit the serotonin uptake in the and kind of give you an antidepressant effect. Okay, and the example is the citalopram, the escitalopram, the fluoxetine, the paroxetine, and the sertraline. And as I was saying earlier, the names can look a little bit strange and you're not familiar with it, but the best thing is for you to say it, write it, even whenever you see it, even though you cannot say it, you will know what it is. There are some medications in psychiatry that I cannot pronounce, and we are going to get there. And I'm sure all of you will laugh at me, but then when I see it, I know what it is. Okay. We have the citalopram, the escitalopram, the fluoxetine, the paroxetine, and the sertraline. And these medications kind of have, provide some side effects, and we should actually watch out for these side effects in our patients. Mind you, side effects is different from adverse effects. If your patient have a side effect to the medication, you just let them know this is a side effect of the medication. It is expected. But if it's adverse effects, they have to stop the medication and you have to notify the provider. So now the side effects of serotonin reuptake inhibitors, we have the nausea, the vomiting, diarrhea, dry mouth. There can be weight loss or weight gain, the sweating and photosensitivity. And the contraindications for this medication is St. John wort. St. John wort is like an herbal medications that they use in treating depression, okay? And you cannot take a selective serotonin reuptake inhibitors with monoamine oxidase inhibitors. And this is because it can cause serotonin syndrome, and that's very, very fatal. It can be fatal, and it is characterized by elevated temperature, muscle rigidity, and altered mental states, diarrhea, nausea, tremors, and reflex changes. I kind of just found this picture online that kind of shows what you will see when the patient is going through is having serotonin syndrome. And basically for serotonin syndrome, you just have to treat symptomatically. You need to notify the provider so they can stop the medication and kind of allow the medication to wash out. Basically, when you're changing from one antidepressant to other, you need to wait for a period of 2 weeks for the medication to wash out before you start another one. I'm not sure I put it in this slide. I'm just letting you know right now. You need to have like a period of 2 weeks before you start another medications. And the second one we are going to talk about is the monoamine oxidase inhibitors, okay? They kind of work on the norepinephrine and the serotonin, okay? They inhibit the monoamine oxidase, which is present in our brain, our blood, our liver, and our spleen, and our kidneys, so that the concentration can increase in the body. And the example is phenelzine, selegiline, isocarbazazide, the trinicyclomine. Okay, the truth out of this thing is that I only know the first two, but when I see the last two, I know they're talking about monoamine oxidase inhibitors. So the phenelzine and selegiline are the common one that they used in Nclex. I think I've seen the third one, but the first two are very common, and you should get familiar with phenelzine and selegiline. The side effect of monoamine oxidase inhibitor is actually dry mouth, weight gain, anticholinergic effects. When I say anticholinergic effect, I'm talking about dry mouth, urinary retention, blood vision. These are things, these are what characterize anticholinergic effects. We have insomnia and restlessness. Monoamine oxidase inhibitors, they have lots of contraindications, and sometimes they are more like the last resort when other medications don't work due to their contraindications. So you can take monoamine oxidase inhibitor with all these listed contraindications. That's the amphetamines, antidepressants, dopamine, epinephrine, some tyramine-containing foods. And there are a lot of foods that contain tyramine. I'm going to show you in the next slide. There are a lot of food that contain tyramine, and this makes it difficult for patients to actually be able to kind of manage it. But when they have to prescribe a patient on monoamine oxidase inhibitors, then it is very, very necessary. And you have to educate your patients on the need to stay away from certain kind of food when they're on these medications. Also, you don't want to take monoamine oxidase with your opiates, because it can cause hypertension or hypotension, coma, or seizure. Okay, so you need to watch out for that also. And here are the listed food that contains tyramine. We have the avocado, banana. We have some caffeine, like our coffee, our tea, chocolate. We have cheese. And when we are talking about cheese, we are talking about aged cheese. So this is commonly, this kind of question is common in Nclex when they are talking about especially multiple especially our starters. Okay, they will put aged cottage cheese. The patient can have cottage cheese, but they can't have aged cheese. So you need to kind of look at that. You can have your aged cheese, but you can't have your aged cheese, but you can have cottage cheese. So you need to take note of that particular food. Our raisins, our red wine, they contain tyramine. And these are a lot of food that a lot of people eat every day. So that's why it's really important to educate your patients whenever they are on monoamine oxidase inhibitor. Like I said, example of monoamine oxidase inhibitor, we have the phenelzine, the selegiline, the isocarbazazide, and the trinicyclomine. These are the 4 common types of monoamine oxidase inhibitors. We have the tricyclic antidepressants. Okay, this class of antidepressants block the norepinephrine and serotonin at the presynaptic junction. I believe we all remember our neurons, our synaptic clefts, synaptic junctions, and all those good stuff. And these are used to treat depression. An example of our tricyclic antidepressant is the amitriptyline, imipramine, desmipramine, doxepin, and so on. So majorly the pityline and the pramine. That's how whenever I see anything that ends with PTYLINE, I know they're talking about tricyclic antidepressants. And when I see anything that ends with PRAMINE, I know they're talking about antidepressants. How I would really like you to read is when you're reading, I would prefer you look for things to join your reading together. So when you see a bunch of medications, look for the ones that actually have the same ending or sound alike. These are the ones you will naturally remember, okay? So that's why I actually picked these 4. And the side effect, again, is the anticholinergic effect. Like I said, our anticholinergic effects are dry mouth, urinary retention, blurry vision, And for tricyclic antidepressants, we have weight gain is one of the side effects, restlessness, and sometimes they can have seizures. Okay, when I say side effects and I mention seizures, you will say this is actually very bad. If your patient is having seizures, they need to inform the doctor and see the doctor if there can be some dose change or they can have their medications changed to another medication. The contraindication of tricyclic antidepressants, we have, you don't want to take them with alcohol because they can cause CNS depression, okay? And you don't want to take them with monoamine oxidase inhibitors because they can cause hypertensive crisis. Okay, I don't think I mentioned that in, okay, I think I did. Okay, so you don't want to take monoamine oxidase inhibitor with just tricyclic antidepressants. So in some of your questions, you will see them actually saying, if you take your provider prescribed some medications, which one will you question, okay? Or which medication will you get some clarification on? If you see a doctor prescribing your monoamine oxidase inhibitor with a tricyclic antidepressant, that's a red flag because that can cause hypertensive crisis. And majorly, and that's a safety question. And majorly in Nclex, our patient safety is very, very important. And for tricyclic antidepressants, you need to do EKG for your patient. ECG should be done before you start the treatment because it can cause some cardiac arrhythmia. So you need to know, you need to keep monitoring the ECG of the patient to know if they have any arrhythmia going on because of the medication. An overdose of this amitriptyline is very, very life-threatening. As you can see, people overdose it because amitriptyline, even though it's used as an antidepressant, is also used to treat insomnia. And they prescribe it to people for insomnia also, and they might abuse it. So overdose is life-threatening and needs immediate treatment, okay? And we will remember our ABC. These are the things we are going to follow when we are managing this condition. You need to maintain the patent airway. You need to be sure there's oxygenation. Do some ECG on them to know the arrhythmia they are in right now. You do some gastric lavage with activated charcoal. This is basically to neutralize the overdose. And you give them anticholinesterase inhibitors, as like a physostigmine. And this is actually used to counteract the effect of the medication also. And you give the antidysrhythmic medication. Depending on the rhythm they have, you need to treat accordingly. Okay. And the last two ones, I'm not going to talk about them much. I'll just give you some examples on them. Are the selective serotonin norepinephrine reuptake inhibitors. That's the SNRI. Serotonin norepinephrine reuptake inhibitors. An example is duloxetine. The duloxetine, the desvenlafaxine, and don't just actually just know the duloxetine. Duloxetine is common, so I think that is a common one. But others, if you can pronounce them, good. But duloxetine is a very common medication. It's commonly used. And that's one I can remember clearly and I know. Also, we have the atypical antidepressants. So we have the bupropion, the mirtazapine, the trazodone. Trazodone is very, very common. Not in the facility here, what I'm familiar with, they don't even use trazodone for antidepressants. They use trazodone to treat insomnia. So trazodone is a very common medication used to treat insomnia in all ages. So trazodone is an example of an atypical antidepressant. Okay. So like I said, you need to know right now is that when your patients are taking antidepressants, okay, you need to let them know that the effect of the medication is not immediate. They need to wait about 2 to 4 weeks for them to see a significant change in their mood. And that needs to be explained to them because sometimes they take this medication, in 1 week, they still feel the same, like this medication is not working. You need to let them know that they need to wait a period of 2 to 4 weeks at least to see the effect of the medication. And also for your patient that will be taking monoamine oxidase inhibitors, you need to let them know to avoid food that contain tyramine. Okay, and this is an education that you have to give them on a continuous basis, because it's very, very easy to kind of forget. So you need to give them that education, and this can cause hypertensive crisis. And another one that I did not have that I would just like everybody to write in their jotters is you need to wait a period of 2 weeks before when you stop with medications to start another one, because you don't want mixing medications to occur, which can lead to serotonin syndrome or hypertensive crisis. Okay. I hope we get that. I'll also go over it again at the end of the class in case of people that missed it. I forgot to add it in this presentation. You need to wait a period of 2 weeks to start another medications. So the next group of psychiatric medications we are going to talk about is mood stabilizers. Okay, so mood stabilizers, they actually enhance our serotonin and our GABA. That's the gamma aminobutyric acid. And they kind of help to elevate the mood. Okay, and lithium is the most common mood stabilizers. It's a common medication used in treating patients that have bipolar. Okay, and the side effect is polyuria, polydipsia, nausea, dry mouth, weight gain, diarrhea, and tremor. Okay, just like monoamine oxidase inhibitor, lithium also have some contraindications. But how I sum up the contraindications of lithium is anything that will make my patient dehydrated, anything that will make my patient lose fluids. They cannot take it with lithium because it can lead to toxicity. So basically, you don't want to take lithium with diuretics. You know, in diuretics, your patients will have to pee a lot. So they are losing fluids in their body. So you don't want to take it with that. You don't want to take it with flexantine. Flexantine is a selective serotonin reuptake inhibitor, and that also can lead to lithium toxicity. You don't want to take it with NSAIDs. It can also lead to lithium toxicity. So all these medications kind of increase the lithium reabsorption by the kidneys and inhibit lithium excretions. And this can lead to risks of lithium toxicity. Okay. Our therapeutic level for lithium is 0.6 to 1.2. So you need to know what the normal serum therapeutic is. For patients that are on lithium therapy, they need to actually do some blood works regularly, okay? You need to do some blood work after they start taking the medication, and then every 1 to 2 months, or whenever there is any behavioral changes, okay? For patients, if you are to take the blood sample of a patient to check the therapeutic level, you need to do it 12 hours after the last dose. So let's say the last dose was given at 8 p.m. The lab should come and draw the therapeutic level of lithium by 8 a.m. in the morning, okay? And what can cause the lithium level to increase in our body is when there is decreased sodium intake, when there is fluid or electrolyte loss, maybe due to sweating, dehydration, diarrhea, or you are taking diuretics, or when the patient is ill, or when there is overdose. Okay. The symptoms of toxicity for lithium start when the lithium level is 1.5. Okay, from 1.5 to 2, then that is toxicity going on right there. And the signs of toxicity is nausea, vomiting, diarrhea, blood vision, slurred speech, hyperreflexia, seizures. These are the signs of toxicity. And when you see this in your patient that is taking lithium, I know nausea and vomiting is a common side effect, but for lithium, it is not a common one. It's showing that the patient is having some signs of toxicity, and that some interventions needs to be done immediately. And one of the interventions that you need to do when you notice your patient is having that is to withhold the lithium and inform the provider, okay? You need to monitor the patient's vital signs and institute some suicidal precautions. And what I want you to take out with this is, For your patient on lithium, you need to let them know that they need to stay hydrated and have some sodium in them, okay? They need to take about 6 to 8 glasses of water every day and have adequate salt intake to prevent lithium toxicity. Okay. And now we are on the antipsychotic medications. Give me a bit. Can I stop scaring me? Okay. Antipsychotic medications. This actually affects dopamine receptors in the brain. Okay. We have the typical antipsychotics and we have the atypical antipsychotics. I know some people are used to first generation, second generation, but what I really want you to take out with this is that typical antipsychotics, they are more effective for the positive symptoms of schizophrenia. And that's the hallucination, the aggressions, the delusions. While the atypical are more effective for the negative symptoms of schizophrenia. Okay, that's the avolition when they are not interested in their environment, the apathy, and the alogia. Okay. For typical antipsychotics, example is our chlorpromazine, our haloperidol, and loxapine. I think everybody's familiar with haloperidol, and that's an example of the typical antipsychotics. With the atypical antipsychotics, we have the clozampine, the olanzapine, the quetiapine, the risperidone. So these atypical antipsychotics, they're actually commonly used more than the typical antipsychotics. So in the facility where I work, it is very, very common for them to actually use quetiapine and olanzapine. And when the patient is having some real aggression, when they are very, very feisty, when they are very, very like maybe they want to harm themselves or harm other people, you see the doctors prescribing Idol, give Idol, but on a normal basis, they take their olanzapine and they take their quetiapine. In case you see it in questions, sometimes they are very fond of using trade name here than generic name, but for Nclex, most of the time, they will put both of them together. So in case you see Seroquel, I'm very familiar with that one, that is also quetiapine. We have some side effects of our antipsychotics. There are a lot of side effects, but they are under different groups. We have the anticholinergic effects. And like I said earlier, the anticholinergic effects are the dry mouth, the blurry vision, the urinary retention. And if there's any other thing I missed, let me know at the end of the class so I can give you the full one. And we have the extrapyramidal side effects, and these are the face twitching, the mask-like face, the shuffling, the sort of like all the signs of Parkinson. That's the extrapyramidal side effects. We have the tardive dyskinesia when your patient is having some facial grimacing, the akathisia when they are just staying in one particular position all the time. And we have weight gain. And in some of them, even in male, you can see them producing some increase in prolactin level, so they can be lactating. And some of the side effects is gynecomastia. And one thing we need to watch out for in our patient taking antipsychotic medication is neuroleptic malignant syndrome, okay? This is a very fatal syndrome and it can occur anytime when the patient is taking antipsychotic medications. And we have it's commonly when they start, especially when they are new to the medication, when this is the first time they are taking the medication, you need to watch them closely for NMS. So it's common during the initiation of therapy, when they change from one medication to other, or when their dose is increased, or when they are using a bunch of medications together. And these are the signs of neuroleptic malignant syndrome. There will be diaphoresis, there will be tachycardia, there will be hyperreflexia, there will be increased bowel sound, they might have diarrhea, and they might have some blurry vision, they might have some tremor, they might have seizures. So you need to really watch out for a patient in NMS. And apart from you instituting your suicidal precautions, you need to institute safety precautions in patients that have NMS. So our intervention is you need to notify the provider, monitor their vital signs, initiate the safety and suicide precautions, and treat symptomatically. Most of the time, when they have this NMS, the doctors probably will just maybe decrease their dose or their dose for some period of time so that they can get over it. For their tachycardia, you can give them some beta blockers, majorly, correct, Lopressor. That's God, I'm even now very used to saying trade names. That's your metoprolol, okay? It really helps in reducing the heart rate. For hyperreflexia, you kind of put them on maybe some seizure medications like levetiracetam, I think it's called Keppra. So you treat it symptomatically until you can reintroduce this medication into their system, because it is just their body kind of having some initial, especially when they are new to it, their body is not used to taking that kind of medication. So it's just like an initial reaction. Most of the time, they don't hold the medication. They don't hold it. They don't stop it because they need it. Do you understand what I'm trying to say? They need it. So you just treat them, watch the medication, and reintroduce it. But the doctors will actually, you need to let the doctors know, and you'll follow the orders when they put it in. And the next one we're going to talk about is our anxiolytics. These are our anti-anxiety medications, and they cause CNS depression. So you need to watch out for that. And they increase the effect of the GABA, that's the gamma aminobutyric acid, to produce relaxation, okay? And our common anxiolytics is the benzodiazepine, and that's one that ends in PAM and LAM. Okay, that's our diazepam, our alprazolam, our lorazepam, our midazolam. So when you see medications ends in LAM, LAM, or PAM, they're talking about the benzodiazepines. Okay, and the common side effect of our benzodiazepine is dizziness, headache, double vision, slurred speech, hypotension, and tremor. You don't want to give a benzodiazepine with patients with some acute narrow angle glaucoma. It is contraindicated, okay? And also, you don't want to stop, you want to teach your patients not to stop taking their anti-anxiety medications abruptly, because they can have withdrawals to it, and it is very life-threatening, okay? To lessen the withdrawal symptoms, you need to let them know that you kind of taper it down over time. Okay, so let's say, for instance, the patient is taking lorazepam, is taking 2 milligrams. You can't just stop them from 2 milligrams to 0. Okay, so this is basically how they do it, especially for patients that are going through alcohol withdrawal. Okay, so when you start your protocol for them, probably they start them with 2 milligrams TDS. They decrease it to 2 milligrams BID. When I say TDS, like 3 times a day, 2 milligrams BID, then you see them taper it down to 1 milligram BID. Then they will eventually stop. So you have to taper it down over a period of time to prevent withdrawal from happening. When there is abrupt withdrawal, or when the medication is stopped abruptly, the patient can have restlessness, insomnia, tremor, sweating, vomiting, and seizures. Okay, and also there can be toxicity when your patient is taking benzodiazepines. That's when they take too much of it. Okay, and this can cause somnolence, confusion, and diminished reflexes, and they can lead to coma. If this occurs, there is an antidote for it, and that's the flumazenil. Flumazenil is a benzodiazepine antidote that is given intravenously to reverse the effect of benzodiazepine intoxication. And it's kind of rapid. It works in about 5 minutes. Okay. Now we are talking about the stimulants. Okay. Stimulants I will link it up with children having attention deficit hyperactivity disorder. That's our ADHD. Okay. CNS stimulants increases agitation and activity in adults, okay, but has a very calming effect in children, okay. And this helps them to increase their alertness and sensitivity to stimuli. Okay. In kids with ADHD, they are a little bit restless. They can't sit down in one place. Okay. They can't get things done without being distracted. So this medication actually kind of relaxes them so that they can focus on getting things done and how it should be. So you will see them, if in class, they just don't want to stay in one place. But this medication actually helps to calm them and relax them. Okay. And side effects of these stimulants is tachycardia. I forgot to actually add the examples. So the example of stimulants, I want you to write this down, is your amphetamine, your methamphetamines. These are the common ones. We have the amphetamines and the methamphetamines, okay? The side effect is tachycardia, anorexia, weight loss, elevated blood pressure, dizziness, and agitation. When children are taking these medications for ADHD, you need to monitor the following. You need to monitor their blood pressure because, like I said, it can cause hypertension. You need to monitor their height and weight, particularly in children, because they can have some growth retardation while taking these medications. Okay. And also, you need to educate the parents whenever they are taking these medications. You need to let them know that the over-the-counter medications should be avoided because it counter the effect of the medication. You need to let the parents know that the last dose of the day should be taken at least 6 hours before bedtime because it can cause insomnia. So you want to give them early, at least for kids, you want to give them their evening dose by 6 p.m. or even earlier than that, depending on when your kids sleep. Like when the parents say the typical time their children sleep, sometimes maybe 4 p.m. You want to give them early so they don't stay awake all through the night. Because this medication increases their alertness, increase their sensitivity, and so you don't want them to stay awake all night. That's why you do this. And you want to let the parent also know that the medications might take several weeks for them to see effects. So they should stick to the regimen and they will see effects in about 2 to 4 weeks or 3 to 5 weeks, they'll start seeing some effects. And also, you need to tell the parent that there can be some medication-free periods so that the kid can grow. Like I said, this medication can cause some growth retardation. So you also want them to grow even though they have HCAD. So there can be some periods where they are not going to take the medications so that they can grow, basically. And the next one is the barbiturates and the sedatives. Okay, these are major medications that are used in treating insomnia. Okay, and also helps in relieving anxiety. And our example is pentobarbital, or the barbitals basically are barbiturates. Okay, and our sedatives is our zolpidem. It is commonly used to treat insomnia, okay, just to relax the patient and make them sleep. And the side effect of this medication is dizziness, drowsiness, confusion, irritability, agranulocytosis, and they can have some purpura rash, okay? Withdrawal symptoms can also occur in this medication, so you need to let them know that they should taper it down to prevent withdrawal symptoms. And when your patients are taking these medications, that's the last one. When your patients are taking these medications, you want to let them know that they should not operate any machines, they shouldn't drive. Safety precautions should be put in place for this patient because the side effect of the medication is dizziness and drowsiness, so they can fall. Okay, and like I said, patient safety is very, very important in nursing generally, and this is what they test in your Nclex. Okay, so I think now I'm going to entertain some questions.
Okay, thank you so much. Before you do the question, there has been some people waiting on the waiting room. I just want to see if I can add them, then we can take questions and then move further, okay?
Okay.
I'm adding them now. Is everyone following? On the comment section, please let us know if you're following. I try to follow up on you guys to see if everyone is following during the lecture. Okay, so we'll have time to take questions. If you have any question, please go to the comment section, drop your question there, and then we can entertain your question. I wouldn't like us to like unmute ourselves because it's going to be rowdy. Unless you know that your environment is very, very calm, you can send a message, then we can add you, we can unmute you directly, and then you ask your questions, okay? Thank you so much, Abisola, all those drugs. I'm happy I work in the OR, I work in the operating room, so I don't have to deal with all those medications. But still, you cannot run away from medications. Just being a nurse, you have to, in one way or the other, do medications during your duty or during the discharge of your duty. All right, so that being said, if you have any question, please let's use the comment section, because if you don't have question, I think our boss today, Boss Abisola, has some questions for us to treat so that we can internalize the topic that we've just treated. So she's going to go through the questions that she has. We will treat those questions together. These are first class Nclex questions, which means even if you don't see exactly the same type of question, probably you're going to see similar questions in your Nclex, okay? So I just want to read out a question from Omoni. Omoni said, please, can atypical be combined with typical antipsychotics? In what condition can that be possible?
Okay. Do you want me to answer?
Yeah, you want to go?
You want to read everything?
Okay, let me read everything.
Okay, let me answer one. Okay, so yes, there can be some instances where the atypical and the typical antipsychotics can be given together, and this is especially in patients that are having schizophrenia. Schizophrenia is the antipsychotics are majorly used in treating schizophrenia, and for a long-term use, because I work also in a mental health facility, for a long-term use, they prefer to use the typical ones. That's the new ones. That's the olanzapine, the quetiapine. They prefer to use that. But if a patient is going through aggression, like the patient is having some delusions, like if you remember when I was talking earlier, I said the atypical, like the old ones, basically. I don't want to say old ones because I'm used to saying that, but the just give me a second, please. Okay, the typical one I used in treating the hallucination, the aggression. So when your patient is having some aggression, when they are hallucinating, they are seeing things, they're telling you, oh, that one is talking to me to go and kill that one. And trust me sincerely, they are very, very honest. They are very, very honest when they are actually telling you things. You will ask them, oh, do you have a plan of killing yourself? And they will tell you, yes. Do you have a plan to? I plan to stab myself. So this kind of patient, you want to give them the typical ones, this alloperidol, your chlorpromazine, you want to give them because that's what is really, really, that will really work for them. But for a long-term use, when they are okay, they normally give them the atypical antipsychotics, especially the olanzapine. I hope I answer your question.
All right. Thank you. Let's see. I don't know. Omoni, did you get that question answered the way you want it? Let me see. Yes, she said yes. And other people are just requesting for us to do a little calculations, draw calculations. You know, that's the other question that we have here. All right. Okay,
Okay.
so thank you. Okay. Okay, somebody say, please, I need to get clearly what you said about antipsychotic is used for negative or positive symptoms of skis. So,
Okay.
yeah.
All right. So the typical antipsychotics is used for the positive symptoms. And what we mean by the positive symptoms is the hallucination. Okay, so we have the visual hallucination, the auditory hallucinations. That's when your patient is saying, I'm hearing things that are obviously not there, or they are seeing things that are obviously not there. Aggression, that's when they are actually harm to themselves and to others. Or delusion, when they are saying what is not. Okay, they can tell you, oh, they are the cousin to the president of wherever, or they have so much of this money in their account, or they feel like they are the best in the room, like grandiosity. So these are what the typical psychotics are used for, while the atypical one are used for avolition. Avolition is when your patient lose interest in their environment. If I'm actually very, very correct right now, but it's one of when they lose interest in their environment. They don't care about the environment. They are just in their own world. Okay, you see them doing things that normally they would not do, maybe just pacing around, walking up and down. They are not at that point, they are actually not aggressive. They are just how will I put it? They are just not interested. They are not in sync to what is going on in their environment. So that's when you want to give them the atypical ones. That's the quetiapine, the risperidone, the olasampin. I hope I answered that question.
Thank you so much. Yeah, you did. Adama Khan is asking if we could do a drug calculations. Okay. We'll see if one of the questions that we have today may be bordering on drug calculation. I don't know, but
I
know.
don't think so.
Okay.
I'll give you a trick. I'll give you a trick to drug calculation, and that's just one formula answer it all. Okay. Available dose over prescribed dose times volume. Okay. So let's say your doctor prescribed 80 milligram of olasampin, and it comes in 50 milligram. Okay. Mm-hmm. How many tablets will you give? Basically, what you have is what's your prescribed dose? The doctor prescribed 80 milligram. And what is the available dose? It comes in 50 milligram times the volume. Because it is a tablet, it will always be 1. Okay. So now, the amount of tablets you're going to give will be 80 divided by 50. Okay, that would be one point something. Let me use my calculator. Hold on a second.
1.6.
Yeah. So basically, you want to give them 1.5 of the medication. Okay. That's basically what you want to do. And let's say, for instance, now your doctor prescribed Aldol, IM. They want you to give IM to a patient that is having severe aggression, this threatening people, wants to kill themselves, wants to kill others. Aldol normally comes in 2 milligram. Aldol comes in about, I think, 2 milligrams. Let's say for instance, Aldol comes in 2 milligrams in 2 meals. Okay, and your doctor said, okay, let's give this patient 4 milligrams of Aldol. Okay, so that would be 4 milligrams are prescribed dose, and 2 milligrams is what the medication comes in, the available dose, and the volume of this medication or the quantity comes in 2. Okay. That means you want to give them 2 bottles of Aldol. That would be 4 meals that you want to give them in total. Do you understand me?
Yeah, yes, we do.
Okay.
We do.
And also, I know most of, in psychiatry, they don't normally ask you for drug calculations. Where you majorly see drug calculation is in the cardiac medications, because that is where it is very, very common in cardiac medications. So, but that's a very long topic on its own. But I want to assure you, if you can find the available dose, if you can find the prescribed dose, if you can find the quantity of the medication, you will always ace it, because that's just a short trick to it. Once you know this is how much the doctor wants me to give, this is how much the pharmacy is bringing, this is the quantity of the medication, you're going to sort out. The major thing in drug calculation is that you need to do your conversions, and that's where people get it wrong. If you don't convert it right, you're going to get a wrong answer. So you need to know your conversions and use that formula, and then you'll be good.
Okay, so much. All right, there's another question that just popped in. Someone is saying, which of the antipsychotics are contraindicated in pregnancy and lactating mothers?
Oh, that's a very good question. Majorly for psych medications, I've never seen an instance where I'm coming. I don't think they are so much contraindicated. But I want to be very, very sure, because I'm not so sure right now. But that's a good question. That's a good question, but let me check.
Okay, while you're checking, let me go through the questions again and see if something popped in. Someone is asking about the recording. Yes, the video is being recorded right now and will be on our YouTube channel. So if you go to our YouTube channel, Decency Nclex Academy channel, you'll be able to see all the previously recorded videos and seminars and virtual classes like this. And then you can also watch this one. All right, so without wasting much of our time, I will add more people and make our guest a host, then we can continue the class. So somebody said, what class of antipsychotics are used in children? So these are questions that we have to answer.
Children take the same antipsychotic as adults. It's just in different dosage. Okay, you give them olasampin, you give them haloperidol, depending on what they come in with. Okay, most of the time. But the major thing about children when you're giving them antipsychotics is that consent needs to be taken for every medication you're giving, and because they are minors, you need to take consent from their parents. But they take the same medications adults take, just in different dosage. Okay.
Okay. All right. They are all contraindicated except LAMO. Somebody is saying they are all contraindicated except something. Let's see. I asked because I have a patient who was psychotic with pregnancy. She gave birth and the child has rashes, and these rashes has lasted for as long as the child was born. 4 months now, the pediatrics has never seen her, yet the rashes are not going. So I'm kind of querying antipsychotics. So somebody, yeah.
Also sure that, but I'm actually trying to do some research right now, because just give me a second.
Okay. So also we have someone said they are all contraindicated except lamotrigine that is acceptable for pregnancy. So
okay.
Said that, and I guess the source was not mentioned. We would have to go further with your questions. I know you have some questions for us.
Many antipsychotics can be safely used during pregnancy. Okay, so that's the atypical ones. That was the olasampin, the quetiapine, the Seroquel, and And this question now that it said, is Seroquel contraindicated in pregnancy? That's quetiapine. They said quetiapine should be used in pregnancy only if the benefits justify the risks. Okay, so most of the time you have to deduct. Because why I said I'm not sure is that I've seen a patient with having schizophrenia and she's pregnant, and we basically give her all the medications that we are supposed to. So that's why I said I'm not so sure of which one. And then another one is aripiprazole. They said there is really no suggestion or any link between aripiprazole and pregnancy. Risperidone, and other antipsychotics during pregnancy. Okay, now they said risperidone and other antipsychotics antipsychotics during pregnancy can lead to neonatal withdrawal. So you need to monitor the babies from few days. That's withdrawal from the medication. So you need to monitor the baby few days after birth. Okay. So that's clozapine. Okay, they say clozapine is contraindicated in pregnancy because it increases the risk of fetal macrosomia. Okay. So yeah, that might be the first contraindication I see. So clozapine is contraindicated in pregnancy. Is our dog contraindicated in pregnancy? Most of them, they just have the neonatal withdrawal, which you have to monitor the babies after giving birth.
Yes. Okay. All right. So that clears it out. So from my own understanding, you just have to weigh the risk and the benefit. So the mother is mentally not balanced, and then the child is there, which I assume to be okay. But if you don't save the mother, you're going to eventually lose the baby. So you have to check what is the benefit and what is the risk, and then you judge from there. So in such conditions, I think they are, just that it depends on case-by-case basis. It's going to be judged on case-by-case basis. All right. So I'm going to let you, jump into your questions, and then we'll do the questions together. What do you guys want? Do you want us to do the questions? Are you going to be? Can I trust you guys to be, very, very well comported, such a way that we can actually use our mute button very well? Don't unmute yourself except you want to talk, so that we can all go through the questions together. There's questions that Abisola has for us today, so we can go through the questions and then, end the class. All right. So let me know in the comment section if you want us to continue using the chat button, to be answering questions, or you want us to unmute ourselves and be very orderly. 1 second to do that. Are we all together? Okay, Sani said, I think chat is better. Chat is better. We might not have the coherence. Okay, all right, the chat have it. So we're going to use the chat button. So she's going to give us the question. She's not going to show us the answer. We're all going to attempt it. Please, we have over 100 people in this chat room. Please, please, please attempt the questions, okay? When you attempt it, don't care about what others are saying. Whatever your instinct says, follow your instinct, answer the question, then we will have the answer with the rationale at the end, okay? So she's first of all going to show us the question, then follow through and answer, then we'll have the rationale at the end, all right? So I'm going to hand over to Abisola now. Abisola, there are some people joining us, so if you don't mind, from time to time, if you can go to the comment section, to the that's the participant page, and then add them. That's the waiting room, because most of them were chatting me up. We can't get into the class. So yeah. Okay. So I will make you the host now. So you can. So go ahead. You are the host now. Go ahead.
Right. I'm the host now.
Mm-hmm.
Ready. Share my screen. Let me just go to questions, sorry. Okay, so our first question is this. It said, a nurse is teaching a client who is being started on imipramine about the medication. The nurse should inform the client to expect maximum desired effects at which time period following the initiation of the medication. The first one is in 2 months. The second, B is in 2 to 3 weeks. C, during the first week. D, during the 6th week of administration. So what do you think the answer will be? Let me see what people are picking. Oh, good. Yeah. I think that's good. Well done, everyone. Let me give some minutes to other people. Okay. I think majority are saying the right answer, which is very good. The correct one is B. That's 2 to 3 weeks, okay? You should let them know that antidepressant medication may take a while for them to have desired effect. This is a very important question because I think I've seen it 1 or 2 times before in questions. You should let them know that the effect does not start immediately, not even in a week. It takes about 2 to 4 weeks. And in some other literatures, they say 3 to 5 weeks. So at least the 2 to 4 weeks bracket is covered right there. So you should let your patient know that, okay? Okay. Our next question is, a client has been on lithium carbonate therapy for 7 days. Which of the following findings will be the most important to report to the healthcare provider? A, diarrhea, vomiting, and mild tremor. B, dry mouth, mild thirst. C, hyperactivity and auditory hallucination. D, a lithium level of 1.3. Let's see what people are saying. Okay. Okay, well done, everyone. Just let's keep the answers coming in. Okay, let me have people add me all. Okay. All right. Okay. Some people got the answer right, and some other people picked D. Remember, I said for you to say there is lithium toxicity, the value has to be 1.5 and above. So D is out of it. The correct answer is A. Okay. Acute lithium toxicity is when it is 1.5 and above. If you still have 1.3, even though, like I said earlier, the normal is for you to be 0.6 to 1.2, okay? The period of 1.3, 1.4 is still, oh, let's manage this thing. But when it's not get to toxicity, when something has to be done, it has to be 1.5 and above, okay? The answer is A, when your patient is having nausea, diarrhea. Remember I said what can actually cause lithium toxicity is when your patients are losing fluids. And when they are vomiting, they are actually losing fluids, and that can increase their risk for lithium toxicity. Okay, So it can be nausea, vomiting, diarrhea, and some neurological symptoms that you're going to see is tremor, confusion, restlessness, sluggishness, and the healthcare provider must be notified when this happens. In a facility where I've worked before, a psychiatric facility, when they draw their labs for lithium every day, every Thursday. Okay, yeah, every Thursday. So that's because they want to know if they are within the therapeutic zone or they are becoming toxic. So you need to check that, and you need to let your provider know as often as possible. Okay. I hope you all get that. Is there any question for me right there on that? Let me go through the chat box and see. It said A cause early symptoms found with GI tracts. That's very good. Okay, let's go to the next question. Okay, a second, please. Okay, another question is still on lithium. It said a nurse has completed teaching a client who is being discharged on lithium for bipolar disorder. Which statement by the client indicates a need for further teaching? A, I need to drink 1 to 2 liters of fluids daily. B, I need to have my blood levels checked periodically. C, I should not limit my sodium intake. D, I should use ibuprofen for pain relief. What do you think the answer is? A nurse has completed teaching a client who is being discharged on lithium for bipolar disorder. Which statement by the client indicates there is a need for further teaching? A, I need to drink 1 to 2 liters of fluid daily. B, I need to have my blood levels checked periodically. C, I should not limit my sodium intake. D, I should use ibuprofen for pain relief. Let me give you a couple of minutes to get to that. Well done, everyone. Well done. Let's keep it coming in. I think majority got this right also. The correct answer is D. Remember when I was talking about contraindications, I mentioned diuretics, that's our Lasix, fluoxetine, and NSAIDs. You don't want to give NSAIDs to a patient that is on lithium because it causes lithium toxicity. And also, it can decrease renal function and dehydration, decreased renal function, diet low in sodium, NSAID can cause lithium toxicity. So D is the correct answer. A is correct. You want to tell them to actually drink 1 to 2 liters of water per day, and that's the equivalent of 6 to 8 glasses of water. And you want to tell them that they need to check their blood levels periodically so they can know if they are therapeutic or they are toxic. And you need to tell them not to limit their sodium intake, okay? Don't tell them not to limit their sodium intake. All right. Do we have any question on that before I go to the next one? If you have any question, just drop it in the chat box, okay? Let me see. Okay, I think we're good. Yeah, very good. All right. So our next question is a nurse in the behavioral unit is reviewing medications and prescription for 4 clients. Which combination of medications should the nurse question? A client with anti-anxiety prescribed with escitalopram and alprazolam. B, a client with bipolar disorder prescribed with peridone and lithium. C, a client with depression prescribed escitalopram and selegiline. And D, a client with depression prescribed sertraline and zolpidem. Let me go over the question again. A nurse on behavioral health unit is reviewing medication prescriptions for 4 clients. Which combination of medication does the nurse question? A client with anxiety prescribed escitalopram and alprazolam. B, a client with bipolar disorder prescribed risperidone and lithium. C, a client with depression prescribed escitalopram and selegiline. And D, a client with depression prescribed sertraline and zolpidem. Let's drop your answers in the chat box and I'll go through it. Oh, you people are fire. Very good. SSRI, oh, that's good. That's good. Yeah, you guys, you definitely some rock stars. Well done, everyone. I think everybody got it right, and I'm very, very happy everybody got it right. That means that you understand, you actually know some examples of SSRIs, and you know some example of monoamine oxidase inhibitor, which is very, very good. So C is our correct answer. You don't want to give monoamine oxidase inhibitor and selective serotonin reuptake inhibitors together. Like I said, you should give at least 2 weeks between each other so that they can be a complete washout before you start another one. Okay, let's just have a little bit of fun before we go to the next question. So what class of drug is escitalopram? No, I think you're going to get that. What class of drug is alprazolam? Let's see. What class of drug is alprazolam? I'm in your chat box, just drop it there. Benzos, that's very good. Alprazolam is an example of benzodiazepines. Like I said, the LAMs and the PAMs. Okay, that's very good. Well done, guys. And what class of drug is zolpidem? What class of drug is zolpidem? I'm still waiting for somebody to write what class of drug is zolpidem. Very good, very good. Zolpidem is a sedative or hypnotics, depending on how you want to call it. That's very good. Well done, everybody. I'm really, really happy everybody is getting that. So majorly, let me just give you some of the medications they use in Nclex. Okay, so that's why you have to read with purpose. Sometimes there are some medications that are very difficult and you will never see it. I'm not saying don't know it, but there are some important medications you should know. For SSRI, you should know your citalopram, your escitalopram, your fluoxetine, your paroxetine, and your sertraline. Those 5 medications are very important for you to know because they use almost all the 5. For your monoamine oxidase inhibitor, they commonly use selegiline. And why they commonly use it is that they kind of want to confuse you with sertraline because they are almost similar. Okay, so you need to know for your monoamine oxidase inhibitor, you need to know selegiline and phenelzine. Those 2 are very, very important. I've seen 1 or 2 questions where they use the isocarboxazid, but even without me pronouncing it well, when I see it, I know it's a monoamine oxidase inhibitor. So well done, guys. What class of drug is risperidone? What class of drug is risperidone? That's very good. Risperidone is an antipsychotic. That's very, very good. Atypical. Are you even specific? Thank you. That's very good. Well done, guys. Well done. All right. Okay. I remember lithium is the most common mood stabilizers, and it is used in treating bipolar disorders. All right, let's go to the next question. Question number 5. A nurse is developing a teaching care plan for the client with prescription to change antidepressant medication from imipramine to phenelzine. Which instruction is appropriate to include in the teaching? Number 1, A, continue avoiding food high in thiamine until the imipramine withdrawal is over. B, skip the nighttime dose of imipramine and start phenelzine in the morning. C, taper down imipramine and discontinue for 2 weeks before starting phenelzine. And D, taper down imipramine while gradually increasing phenelzine. Let me go over the question again. A nurse develops a teaching care plan for a client with prescription to change antidepressant medications from imipramine to phenelzine. Which instruction is appropriate to include in the teaching? A, continue avoiding food high in thiamine until the imipramine withdrawal period is over. B, skip the night dose of imipramine and start phenelzine next morning. C, taper down imipramine, then discontinue for 2 weeks before starting phenelzine. D, taper down imipramine while gradually increasing phenelzine. I see. Well done, everyone. I think that was it. That was a cheat question because I just talked about it. Right now. Yes, that is true. You need to taper down the imipramine, discontinue for 2 weeks, then start with phenelzine. Okay. That's the correct answer. The caution must be taken when you're switching from a tricyclic. Imipramine is a tricyclic antidepressant to a monoamine oxidase because it can cause hypertensive crisis. Okay, so you need to allow a period of washout. Question 4 and 5 are basically the same. Well done, guys. Well done. It shows you're following. Well done. And I think my last question is this. A child with attention deficit hyperactive disorder has been taking methylphenidate for a year. Methylphenidate is an example of a stimulant, okay? What are the priority nursing assessments when a client comes to the clinic for a well child visit? A, attention span and activity level. B, dental health and mouth dryness. C, height and weight and blood pressure. D, progress with schoolwork and in making friends. A child with attention deficit hyperactive disorder has been taking methylphenidate for a year. What are the priority nursing assessments when the client comes to the clinic for a well child visit? A, attention span and activity level. B, dental health and mouth dryness. C, height, weight, and blood pressure. D, progress with schoolwork and in making friends. Let's see. Okay. Okay. I think everybody's between A, C, and D. Okay. Okay, let's see. Okay, so when they say priority questions in Nclex, basically all of the answers are correct. But they want you to know, they want to ask you which one is the most important. Okay, that's what it means. So yes, you need to know their attention span, because like HCHD, they are restless. You want to know if they can sit still and actually finish a particular assignment. Okay. You want to also check their dental health. You want to check their height and weight. Everything is actually very good for a nurse to assess whenever they come to the clinic. But the question is asking us, which one is priority? And the most priority is our height, weight, and blood pressure. Okay, the answer is C. Okay, the side effect is, like I said, it can cause some growth retardation and it can cause some increased blood pressure. So you need to monitor that whenever they come to the clinic. Okay. Okay. So before I end the class, let me just run over everything that we've said all through the day. And if you have any question, let me know right now, because it's like the last time I have to answer any question anybody have. So today we talked about the the psychiatric medications, and we talked about their different classes. We talked about the antidepressants, we talked about the antipsychotics, the lithium, mood stabilizers. We talked about anti-anxiety, that's the benzodiazepines. And we talked about the stimulants, we talked about the sedatives. So basically for antidepressants, what I want you to always remember is you don't mix SSRIs, you don't mix medications basically. You don't mix SSRI, that's a selective serotonin reuptake inhibitors with monoamine oxidase inhibitors, because it can cause serotonin syndrome, and it can cause, if you mix monoamine oxidase inhibitors with another antidepressant, it can cause hypertensive crisis. You need to let your patients know that it takes about 2 to 4 weeks for them to see effects in the medication. And for patients taking monoamine oxidase inhibitors, it has a lot of contraindication, especially with their food. So you need to let them know the type of food they can eat, okay? And like I said earlier, they normally test the cheese. They cannot have aged cheese, but they can have cottage cheese. So you need to take in cognizance to that one too. And also for our antipsychotics, you need to monitor your patients for NMS. Okay, and this occurs when they start the therapy, or when there's a dose change, or when there's a combination of medications together. So you need to monitor your patients for neuroleptic malignant syndrome when they are antipsychotics. And we talk about the different antipsychotics. We have the typical and the atypical. Like I said, example of the typical is the outdoor that everybody knows, and the atypical is the olanzapine, the risperidone, the quetiapine. These are the common ones. And for your lithium, and that's your mood stabilizers, you need to let your patient know that they should not get dehydrated, basically, because once they are dehydrated, they are at risk of having lithium toxicity. Okay, so you want to tell them to avoid, when they are on it, you need to diuretics, fluoxetine, NSAIDs. This can place your patient at risk of lithium toxicity. And what can actually cause it is when they are not taking enough sodium, when they are having diarrhea, they are on laxes, they are sweating profusely. This makes them lose fluid in their body, and they can have toxicity with that. And our normal lithium therapeutic level is 0.6 to 1.2. Lithium toxicity starts when it's 1.5. And when you're having a patient that is having nausea, vomiting, it is not a side effect. It's showing some signs of toxicity, okay? And you want to tell your patient to stay hydrated. They drink about 1 to 2 liters or 6 to 8 glasses of water every day, and maintain their sodium intake, okay? And we talked about anti-anxiety medications. That's the PAM and the LAMS, okay? They can have they should taper it down. They should not stop it abruptly. And when there is overdose, the antidote is flumazenil, which can be given intravenously. Okay. And we talked about our stimulants for our kids, especially kids with ADHD. You need to monitor their growth. You need to monitor their blood pressure when they are taking this medication. And you need to let the parents know that the last dose should be given at least 6 hours before the bedtime to prevent insomnia. Okay. An example of these medications that I forgot to put it on the slide is methylphenidate, methamphetamines, and amphetamines. Okay. Just kind of help me write that down somewhere. I will talk about our sedatives, that's our hypnotics. Safety is very, very important when they are taking this medication because it causes drowsiness and slowness and dizziness. And you don't want them to operate any machineries at that particular time when they are taking these medications. I just run through everything. If anybody, for some last minute, if there's any question, just put it down in the chat box and let me check it out. Let me see. Yeah, I think we are all good. Thank you so much for having me, everybody. I really appreciate it. This is the first time I'm going to be on screen, so I really, really don't like it.
She is a private person, but we got her today. Yeah. I just want to tell you that you did a nice job. You know, we've been teaching. She has been a teacher. She's been teaching, but she does this online that we do, like, you know, online, but you're not like on screen like we're doing it today. Today is my first time of putting her on the spot and spotlight. And then, you know what? She surprised me. She went above and beyond. And I'm really, really proud of you. Thank you so much for coming through with that beautiful presentation. We really appreciate you. Thank you very much. And then all the people that made it to come, like made our time to come to the presentation today, I want to say a very big thank you. Thank you for coming in. You know, we've been, you know, bringing you free Nclex lectures and free seminars, all because of our passion to make sure that you got the right information to be able to assist you with your process. One thing I want to let you all know is that Abisola was once like you. She worked in Nigerian hospitals like everyone. She went into, she got the dream of coming to the United States, pursued her dream. Today, she's living her dream. And that is exactly what I want everybody that is hearing me today to do. If you have not started pursuing your dream, if you are just there thinking it's not true, thinking all these things they are saying and, you know, it's not true, don't think that. She's a life witness, and I am one too. I was once working in Nigeria in different health institutions, and here I am today. And by the grace of God, we are here doing what we can to make sure that lots and lots of nurses get the right information, make sure that they are not scammed, and make sure that they come to the United States or any other country of their dream in the fastest possible time. So we are processing for UK, we are processing for US. So if you're interested in any of that, go ahead and contact any of the admins in all our platforms, and we'll be able to give you the right direction. Okay. I want to say big thank you again to Abisola. Abisola, thank you so much. We really appreciate you coming. You wanted to say something, maybe last minute words to everybody. Just encourage people. I know you can do that. Just encourage them. They are nurses, and they would just appreciate one or two few words from you going forward. Okay. I think you're muted. Sorry, you're muted. You're still muted. Sorry. I can actually unmute you. Let me find you. Let me find you now. Where are you hiding?
Okay. What I normally tell everybody about any encounter is make it an habit to read every day. If it's at least 2 hours every day, you don't want to go a very long while without reading your books. So make it an habit to read. Sounders is a very, very good textbook for you to actually use to read your book. So make it an habit to read every day, as I would recommend Sounders, and do some U-word. And also read smart, okay? When you see the textbook, you'll be afraid, okay? But you need to read smart. You need to be able to know what is important for you to remember. It's not like the textbook is not important, but you need to know what is important for you to remember. And like I said, see how I actually just went through the old slides with my last words. These are very important things I always remember. Not that I don't remember every other thing. Read smart, make it an habit to read every 2 hours every day. Sounders is a good one. I know U-word and Archer are very good right now. And even with this new Nclex question that is coming out, don't be scared. Don't be scared at all. It's a scenario based, and I want to believe with a very good basis in your content. So make it an habit to actually attend your content classes. In content, once you are grounded in content, the exam will be as smooth as possible. And also pray. Okay, pray as if you did not read, and read as if you did not pray. So balance both of them, and do not be afraid. Whatever fear is the number one cause of failure. Once you start this journey, make it an habit to say, I'm going to pass, okay? Read and don't let fear overthrow you, because once you start doubting yourself, it's like everything in your brain just fly away. So that's all I have to say. Just please read every day. That one is very, very important, because once you skip a day, you have to cover it up. So make it an habit to read every day. And
awesome.
Yeah.
Thank you so much. I felt like she should stop. She should continue. She should not stop. She should continue talking, because these are words that, they're hard to come by, but she's telling you the truth. So many people think, it's Nclex, and then they'll figure out when they get to the exam hall. This is something you have to build. Have to build that content base. That's why the Decency Nclex academic content class is very, very important. It's a foundation class. It's a no-joke class. If you go there, if you don't pass, you're not graduating. You have to make sure that you are well-grounded in your content before you can even start attempting questions. No need of getting, you see, Archer and U-word, they're all question banks, okay? So we get to it when we are well-grounded in our content. But for now, if you haven't really started, first thing to do is get your footing, get used to the terms, get used to Nclex, get used to the basic terminologies, get into the content class. It's a foundation class where we build every other thing you get after your content class is just like you're consolidating on what you have already known. And that is very, very important point she made. I'm going to let her go now. I know she has a lot of program. In fact, she went on night duty, and here she is today, and she was able to deliver smartly. Somebody is saying, how can I read smart? How can I, read smart? So reading smart is actually number one. I would take that question. Number one way of reading smart is being able to get in touch with people who have gone this road with before. They will be able to at least guide you, and where you find them is in academies like Decency Academy. You'll be able to get people who will say, okay, this is how to go about it. Like she was talking, the textbook is so voluminous, but with the content class, we are going through those topics that we feel these are the areas that Nclex always go and always repeats. And also, by the time you start reviewing your past questions, you can use your past questions to go back and revisit the topics that you're not well grounded in. So let's take, for instance, I'm reading a question and it's talking about cystic fibrosis, and I don't know anything about cystic fibrosis. What do? I go back to my textbooks and go and read about cystic fibrosis, not just, I don't know it and then you go. So every knowledge you get now is going to help. Even if you don't see it on Nclex, one day in the clinical area, you'll be able to see it. In fact, we've had a hospital in Nigeria approach us for us to train their nurses, not because those nurses were traveling abroad, just because they want to improve patient care in their hospital. So people are actually building clinical competencies, not just for you to be able to travel or you to be able to pass exams. Okay, so also be in a group where you can get to know what is happening. Some people don't know there are changes in the Nclex. Some people are not even prepared for it. Now I'm announcing to you that the Nclex Academy has organized another presentation coming up next 2 weeks. It's going to be on next generation Nclex questions. You don't want to miss that presentation. Okay, so make sure you keep a date with us. The flyer is on the chat group. Go there, look at it. The boss is already prepared. She's going to give you all that you need to know, at least the introduction to next gen Nclex questions. And then we will continue to go from there. And then we have a class that is the virtual classes that will be handling just virtual classes like this, where we'll come in and treat questions and treat topics. We use it to do our contents, you know, and all that. That class is coming up. Look out for it. By the time it comes up, we'll see our flyer go out, okay? So thank you so much, Abisola. We really appreciate you coming. Thank you so much to everyone that is here. I'm going to stop the recording now, and then I'll unmute everybody so we can all relate, okay?